Good morning, everybody, and welcome to Child and Adolescent Grand Rounds. I'm John Passantini, and it is my distinct pleasure to introduce Dr. Tara Peris. Dr. Peris is a professor of psychiatry and biobehavioral sciences, and currently the vice chair for research for the Department of Psychiatry and associate director of the Division of Child and Adolescent Psychiatry. In addition, she's the program director of the UCLA ABC Partial Hospitalization Program and co-director of the UCLA Child OCD Anxiety and Tic Disorders Program. This is really only a handful of the many roles she plays in the department and the division. She's been very active in leadership and helping us move forward through participation or really leading a strategic planning initiative a couple of years ago. Dr. Peris's research and clinical interests focus on evidence-based assessment and treatment of anxiety, OCD, and related disorders. Her work has been funded by the National Institute of Mental Health, the Patient-Centered Research Institute, the National Science Foundation, and other private foundations. She's a recipient of an early career award from APA's Society for Clinical Child and Adolescent Psychology, a group for which she's been in leadership for the last several years, and a 2024 Fulbright Award recipient. Most importantly, she's one of my closest colleagues at UCLA. We've worked together for 20 years. And as you will see from this presentation, she is really an amazing researcher, clinician, and human being. Her talk today is called Improving Access and Outcomes for Youth Anxiety Treatment. And I can't read the rest of it, but I'll let her introduce it for you. Tara, go ahead.
Thank you so much. Hang on, let's see. All right, can everybody see that okay? I think so. All right, well, good morning, everyone, and thank you for being here. Thank you, John, for that really warm introduction. I feel fortunate to get to do this talk bookended by my dear friend and mentor of 20 years, as John said. And so much of this work is really a collaboration and just the product of many, many years of work together. So I'm excited to share some of this with you today. So what I hope to do over the next 45 minutes or so is talk a bit about the evidence base for child and adolescent anxiety disorders. Now, this will be familiar to many of you, but I think it's a good starting point to make sure we have a shared understanding of the landscape. And that's particularly important because, as many of you are aware, there are numerous barriers to accessing these treatments. So we'll talk a bit about those barriers, the challenges that the field is facing. And then we'll turn toward the potential that collaborative care models have for addressing these needs, particularly the potential that they have to expand access to care for diverse and more representative groups of kids with anxiety. So to get us started, it's important to recognize that anxiety disorders represent a common but really significant mental health concern. These have major public health impact. Anxiety disorders are among the most common things that both children and adults seek mental health treatment for. And epidemiological studies tell us that approximately 1 in 3 youth will meet lifetime criteria by the age of 18. So those are huge numbers, roughly 30% of kids by age 18. And we tend to think of anxiety disorders as gateway conditions. And by that, we mean that they emerge earlier in the lifespan, and they tend to onset and pave the way for other conditions such as depression and substance use. And I'll be sharing some data on that momentarily. We also know that these disorders end up being really costly. Of course, there's the personal toll for kids and their families. There's the stress and concern of all of it. But there's also significant financial concern. These end up being among the top 20 drivers of healthcare costs for people under the age of 18. And when you look more closely at those data, it's really quite significant. They're up there with things like asthma care, diabetes, other major chronic health conditions. What you see here are just some data on age of onset trends. And so we can begin by just looking at the panel on the left, panel A, and just track that line there in red for anxiety disorders. You can see that it's showing us the age of onset, and we can see very clearly that these conditions tend to come online earlier in the lifespan compared to substance use there in green and depressive disorders there in gray. I will note, if you just check that green line, how the sharp increase in adolescence, but anxiety disorders have already been there for a while. If you look over to the panel on the right, we can see how this breaks out based on anxiety disorder. Not surprisingly, we see specific phobias emerging earlier. But again, track that blue line for social phobia. We see really kind of sharp increases as kids head into and through adolescence. Lots of things predict anxiety disorders. I'm showing you some data here from the ABCD study during COVID. And there's lots and lots of, longstanding longitudinal data looking at both genetic risk and environmental risk. Here we see, higher rates of vulnerability for females, but also some potentially modifiable risk factors. So things like positive tone or communication with parents, quality of relationships with family members. These things always pop to me because there's things we can do about it. I also want to highlight that during the pandemic, witnessing racism or discrimination related to the coronavirus was also one of the top predictors. Again, I would hope that that would be something modifiable too. Impact. So I think all of this is pointing to things that are common and costly. They're also chronic. So child anxiety predicts adolescent anxiety. Adolescent anxiety predicts adult anxiety. This is really important for us to convey to the kids and families that we work with. Because anxiety, like all other emotions, is natural, necessary, harmless, it's part of the human experience. I think people tend to see it and think, oh, this is just a stage, it's going to pass, let's ride it out a little bit longer. And that may be true for more developmentally typical experiences of anxiety. But when it comes to anxiety disorder, we know that it's not likely to improve on its own. And indeed, it's likely to persist over time. And then we know that these disorders predict increased risk for later depression and substance use. They also predict later risk for academic and occupational underachievement. And this makes a lot of sense when you think about the hallmark feature of anxiety disorders being avoidance. These kids may be less likely to try out for teams, take initiative, raise their hand and ask for help, seek clarification when they need it. That escape or avoidance tendency may really rob them of important opportunities for advancement. Thankfully, we have treatments that work. You guys are all familiar with, I think, the basics of our evidence base, but certainly both pharmacotherapy with SSRIs or SNRIs and CBT, proven effective, again, as monotherapies or together. I'm showing you here data from a meta-analysis by Jeff Strawn, just sort of summarizing, and this is a paper that we cite often, just summarizing the evidence base for the use of SSRIs for peds anxiety. And you can see that on balance, they are shown to produce a moderate effect size. There's a trend for activation as a side effect. And we see that sertraline is the option with the most robust evidence. Likewise, if we think about our psychosocial side of things, there's really robust evidence for exposure-based CBT. It's probably one of the most well-supported psychosocial treatments out there. The paper that I cite down here at the bottom, Higa Macmillan, as you can see, is from 2016, and that the title of that paper is already 50 years of evidence for exposure-based CBT. So this is really tried and true. The challenge is that there are fewer RCTs that have used active comparisons. This is really tricky when we are thinking about sort of what's the reference point for how well a particular treatment is doing. We do have really nice follow-up data, though, from work by Phil Kendall and others showing that kids who make gains in CBT are likely to maintain them, as far out as 1 year follow-up. Some of the challenge, though, is that translation to the community is pretty tough. Many of you out there who focus your own work on dissemination and implementation know that a lot of times CBT that does really well in highly monitored and highly regulated research settings doesn't do as well in the community. And in some studies, it hasn't even separated from usual care in community clinics. And we think that this is because it really requires pretty rigorous training. And lots of people get training, but then don't turn around and put what they've learned into practice. There are a lot of challenges and constraints in real world settings that we don't have in academic medical center settings. And of course, it requires cooperation and investment from both clinician and patient. What you see here are just some data on sort of the timeline to response. And I like to just reference these data when talking to parents about their options. We know that both meds and CBT work pretty well. Families have a choice. But what they should know is that it's going to take a little while for everything to work. We're all pretty familiar with okay, 6 weeks, 8 weeks for your meds to optimize. The truth is it's going to take about that long, if not longer, for your CBT response to emerge. And if we look more closely at why that is, you can think about the components that are involved in CBT for youth anxiety. Typically, these are protocols where we spend the first half of treatment really focused on skills building, and then we turn in the second half of treatment to applying those skills to real-world practice through exposure. And so you can see here in the blue line for CBT monotherapy and the red line for combination treatment, that's sertraline plus CBT. Really the steepest gains, that the fastest rate of improvement comes after the onset of exposure therapy. That first dotted line that you see on the left is the onset of cognitive restructuring. So we are getting some gains there, which I think is really nice to see. But exposure is where it's at. And so when families are thinking about this as a treatment option, we need to kind of orient them to what this process looks like and what they might want to consider in terms of how quickly their child is likely to feel better. So how do these treatments do? Well, I think everybody by now is very familiar with the CAM study, the Child and Adolescent Anxiety Multimodal Treatment Study. We were fortunate that UCLA was one of the treatment sites under John's wise leadership. I was fortunate to be a trainee and to get to participate and learn so much from leaders in the field. And really what that study told us is that combination treatment is best. Kids who got 12 weeks of acute treatment with CBT and sertraline had an 81% response rate. If you had sertraline monotherapy, it was 55%. CBT coming in as a monotherapy at 60%, and that placebo response rate at 24%. Still a really high placebo response rate. We know from other work by Jeff Strawn that placebo response rate is really evident in the first few weeks, but if you track it farther out over time, it starts to attenuate, and then you see people saying, I don't know, I'm still pretty anxious. But an important question is what happens over time. And what I'm showing you here are findings from a paper that John led, looking at longer term follow-ups in the CAM study. So acute treatment ended at week 12, and families were available to pursue other treatments. And I should say that if you were in the placebo arm, obviously you got your choice. But really everybody here is now pursuing treatments that they think are best. You can see rates of response and remission over here on the right. But I want you to notice that by week 36, everything has sort of collapsed and there's no real difference. And that's something to kind of puzzle over and try to understand, how meaningful are the differences among these options. Why am I not moving on? Okay, sorry. And if we look more closely at remission, I think that can be really instructive too. So we're looking here at combination treatment and CBT. And you can see that at 12 weeks, it's a really profound difference. 66% of the kids getting combination treatment have remitted versus 35 in CBT. By 24 weeks, it's a 20% difference. But again, out there at 36 weeks, it's really shrunk. And it's hard to know, is that because they've received other treatments? Kind of what's going on there? But the magnitude of the difference doesn't seem so pronounced. And this is important when we think about kind of families' preference and how we want to guide them in their thinking about clinical decision making here. So to summarize, we have treatments. They generally work in the short term. CBT as a monotherapy is comparable to med, but slower to show its effects. SSRIs are effective. That's important when we think about the fact that CBT may be difficult to access. They certainly may be preferred if we have comorbidities for which they could be helpful. We do want to be mindful, though, of kind of parent and patient preference and the challenge that sometimes parents are a little bit reluctant to pursue medication as a frontline option. Either way, it can be really helpful to share with families that combination treatment produces clearly superior outcomes. I know that in my practice, I like to talk about these really as options that all offer benefit. But for kids with more moderate to severe anxiety, we know that combination is the better option. So, my recommendations are really based on an assessment of symptom severity. So what if we look a little bit farther out? Well, we had the opportunity to follow the kids who were treated in the CAM study, and it was 468 kids originally treated in that study across 6 sites. We were able to follow them up in a subsequent 5-year prospective naturalistic follow-up study, where we really tracked their outcomes as these kids entered early adulthood. And this is really a neat opportunity. CAMS remains the only study to do these comparisons of kind of our major treatment options in a head-to-head fashion. All of these kids got really high quality, excellent evidence-based care, that really the best version of these treatments that you could imagine. So what do they look like 6.5, 7 years later as they enter early adulthood? The aims of CAMELS were to examine whether early effective treatment or treatment type protected against long-term clinical or functional disability, to look at other predictors of long-term outcomes, and to do this primarily by an annual evidence-based, very comprehensive assessment done with an independent evaluator, with phone assessments done every 6 months in between. So basically a combination of clinical interview and self-report with multiple time points to allow us to piece together these trajectories over time. What you see here is kind of a snapshot of what, for me, is the main take-home message of following these kids over time. We found that roughly 22% of kids were what we called consistent remitters or stable remitters. And this means that every single time we saw them, they were doing well. They did not have an anxiety disorder diagnosis of any kind. We have kids who were chronically ill, and that's really unfortunate. And in the total sample, just about 30% of our kids were chronically ill, which means that at every single visit, they were sick with an anxiety disorder. And then just under 50%, the biggest bin, for those kids were designated as relapsers. And what that means is that over the course of the follow-up window, this was about 4.5 years of follow-up assessments. Sometimes you were doing well, you didn't have an anxiety disorder, and sometimes it had popped back up and you were above the clinical threshold. Lots of things predicted this group status. Importantly, your original CAMS treatment assignment did not. So it really didn't matter if you had med monotherapy, CBT, combination, but how you did in that treatment mattered. Whether you were a responder or a remitter was important. We saw that family functioning, kids with poorer family functioning were more likely to have worse clinical outcomes, kids with more negative life events. Unfortunately, girls were likely to fare worse over time. And not surprisingly, the kids who started out the most sick were most likely to end up in that chronically ill category. As were kids from lower SES backgrounds. And I think that's one for us to really take a moment to register, that it's not a level playing field here in terms of accessing services, which I'll talk about in a moment. But also the types of stressors with which these kids contend. And SES is, of course, likely to influence your ability to access and afford these treatments. Findings from CAMELS are also really important when we think about kind of the larger landscape for youth anxiety disorder treatment, because they tell us a lot about the importance of remission. In early adulthood, CAMS acute treatment responders and remitters had better global functioning. But it was only the remitters who showed less impairment kind of in a consistent way across key domains of functioning. Things like academics, self-care, social relationships. These people had, if you achieved remission in CAMS in early adulthood, you were doing better in what we tend to view as kind of the key developmental milestones of early adulthood: having a strong peer network, strong academic or occupational performance, self-care and self-sufficiency. These are really important outcomes, and remission mattered a lot for them. Acute treatment remission also predicted lower levels of depressive symptomatology and the absence of SI in early adulthood. We should also take a minute to think about our relapsers. So remission is important, and those kids who were consistently well are cause to celebrate. But almost half of the kids who got really high quality care in CAMS basically still had this chronic fluctuating clinical course as they entered early adulthood. And it's hard to imagine how you could have improved upon CAMS treatment, really beyond the tightly regulated ways in which it was administered. So I think what you're seeing here is that these are persistent, kind of pernicious, chronic conditions that really require us to think differently about the model of care. CAMS treatment was only 12 weeks of acute treatment, and in hindsight, it's a bit unrealistic to think that that's going to permanently shift the dial. We really, based on these findings, need to be thinking more about models of care that allow for boosters, ongoing contact with providers, and more maintenance care. We also know from work done by our group that kids in the CAMS study accessed relatively low rates of service use over time and extremely low rates of CBT use over time, which may be one contributor, again, to this fluctuating course. Now, I think a reasonable question is, does any of this matter, this great evidence base we're trying to build and understand, if you can't access care at all? And this is a really fair question, because we know that among kids with anxiety disorders, these are conditions that are generally overlooked and undertreated in the community. And really only 10 to 15% of kids with these disorders get care of any kind, including just sort of supportive care or a single consultation visit. The percentage that get evidence-based care is alarmingly low. A recent study by Kathy Cresswell's group found that it was under 3%, a pretty large and robust sample. Families said that they really had a hard time knowing when anxiety was a problem, and they really didn't know kind of how to distinguish what was evidence-based care or how to get to it. So I think this ends up being a really important paper, both for highlighting the challenges with access, but also what some of the barriers are. We know that there are huge disparities for kids and families of color based on socioeconomic resources. There's also an education gap about when is this a problem and where do I go? all of this points toward considering integrated care models. And I want to really acknowledge important work by Ken Wells and Jonah Sarno in our department and in our division, really leading the way here. Integrated care or collaborative care is really a framework in which we partner in primary care settings so that mental health services can be provided in a way that is more seamless and hopefully expands access. For those of you who are interested in these models of care, Joan has a 2015 paper that I think is a really important overview, and it highlights that these models of care can look like a lot of different things. Sometimes there are psychologists or social workers embedded, in a PEDS primary care clinic, and they're just there continuously on site. Sometimes there are consultation models or sort of triage systems that are set up. But fundamentally, what these approaches share is that they're trying to take advantage of the existing relationships that kids have with their healthcare providers. Despite all the flaws in our healthcare system, the vast majority of American youth will have access with a pediatrician annually. This is something that I have, taken a lot of, I guess, it's been heartening to me to see that despite all of the disparities, most kids make it to a pediatrician each year. So if we can see them and get to them where they're at, in settings where they already show up, maybe we will be better suited to screen and identify and get these kids connected with care. We know that integrated care is really optimal for the treatment of chronic health conditions, and we've just talked about anxiety as being conceptualized in that way, precisely because there's ongoing contact. There's more opportunity for follow-up. And these approaches have already been really successful for depression. I'm thinking of Joan's YPIC study, and for ADHD, great work by David Kulko, just showing us how well this can work. So it leaves us with a couple of key questions. We've seen integrated care or collaborative care approaches work for other common youth mental health problems, but it's really never been robustly tested for youth anxiety disorders. There is some work by Robin Wiersing, kind of building interventions in primary care, but there's not a lot of replication. There's not kind of large samples to help us understand the nuances of how this works. We also don't really know how anxiety treatments perform in more naturalistic settings. We do have data on kind of CBT in more naturalistic settings, but we have less data on what happens when pediatricians are in charge of medication management. And this is important because we know that nationwide and worldwide, we have a shortage of child and adolescent psychiatrists. We hope our amazing training program, takes steps to fill that gap, but the level of need, as you all know, is enormous. And so we simply need, more ways for kids to access these treatments, but we don't have a lot of information about how pediatricians do when they're in charge. We also only have a single study comparing combination treatment to CBT monotherapy. And the reason, this is always problematic, right? The field is really emphasizing the need for replication. But it's also problematic because in a classic efficacy trial, we do all sorts of things to make sure that the treatment is standardized and very consistently administered. This is important, of course, for establishing quality assurance and adherence and fidelity to the treatments as they were intended to be administered. But the trade-off is that it might not look a whole lot or really anything like what expert clinicians do in practice, where they have much more freedom and flexibility based on their clinical judgment to prioritize different treatment components. In CAMS, CBT was truncated to 12 weeks, even though the original protocol for coping CAT was designed to be 16 to 20 weeks. It had a very systematized administration schedule. But in that schedule, clinicians didn't even meet with the family until 4 weeks in, which is kind of wild if you think about it. Like try to imagine any other aspect of your treatment where you don't have any family contact till a month in. And because of the rigid administration sequence and the shorter timeline, there was actually not that much time for exposure practice. If you've got 12 sessions and you're not really starting exposure till week 6, and the last session is really your wrap up, you're trying to get a lot done in a pretty short period of time. So I think we have rightful questions about what happens when the approach is loosened, it's a little bit longer, it's more flexible, and important questions about, what happens when we really focus on remission. We raise the standard and make that the ultimate goal, because we can see that it confers clear advantages. So all of this paves the way for a study that we have ongoing at UCLA. We're really excited about it. We are really in the final stages. We have just wrapped enrollment, and we are in the final stages of treating our last kids in this study. But Partners in Caring for Anxious Youth is a 3-site multi-site study that is asking the following questions. How do CBT and combination treatment compare when used in a collaborative or integrated care model? Which one is better for reaching remission? Which of these treatments is most durable at follow-up? And what are early markers for remission that might help us strategize about, how best to use our resources? For an overview of the study, PK is a pragmatic randomized comparative effectiveness trial funded by PCORI. That's a mouthful. I know many of you heard the great presentation from the YSAM team, from Joan and Jocelyn at the last Child Grand Rounds. We're really, really fortunate to have this great record of funding with PCORI. And this study has, as I mentioned, taken place across 3 sites. The others are Northwestern at Lurie Children's Hospital, University of Cincinnati and Cincinnati Children's Hospital, and our site here at UCLA. I did neglect on this slide to mention that we have also partnered with CHOC, Children's Hospital of Orange County, with a great team of collaborators there as well. We've recruited kids ages 7 to 17 years. They are identified in PEDS primary care settings. And so the idea here is that we try our best to use universal screening measures. This has always been the goal for kids and families to fill out, brief questionnaires at the start of a routine wellness visit, and they could be used to flag potential concerns. I'll tell you now that this, from the very earliest days of planning this study, this was a challenge. And we have really amazing PEDS partners here, Barb Mashitsky, Carlos Lerner, Martin Anderson. We could not have asked for just a better team of collaborators and partners. But their very first question was, how short can that screener be? Well, my favorite is the SCARED, and that has 53 items, so that's kind of a no-go. And there's an abbreviated SCARED, but basically at every turn, everybody was like, could it be shorter? Could it just be 2 questions? Could it be 1? So we ended up with a strategy where we had a combination of potential screeners that pediatricians could elect to use in their practices if they were feasible. But we also allowed referral based on spontaneous report during the visit. And we ended up using flyers in private practice settings as well. But pediatricians identified potential cases, they referred them to us. Kids are randomized to CBT only or to CBT plus med. And the outcome that we are tracking is remission at week 24. And then we've got an additional 6-month follow-up. I think I talked a little bit about the screening. One thing that happened after kids were referred to the study team, so the pediatrician identifies them, they get referred to the PK team, say here at UCLA. We talked about the study, and if families were interested and willing to consent, we then sent them an at-home assessment battery. Again, our focus here was on trying to shift out of a classic efficacy trial frame where everybody comes into the lab, it's like 6 or 7 hours of pretty extensive testing. We wanted something that could actually, maybe in some ways generalize to more naturalistic settings. And the idea of sending kids and families home to complete some things at their leisure, send them back to us, have them scored, and then have them come in for a follow-up visit seemed to fit that goal. So kids and families did this at-home assessment. It included a self-administered mini, which is a semi-structured diagnostic interview that anyone who rotates through ABC is familiar with. They then came into the lab for an in-person diagnostic confirmation visit with one of our study clinicians. Usually at that visit, we're just reviewing the clinical information that they've provided, but we're also checking really just to be sure on any diagnoses that they were flagged for on the mini, making sure that it passes muster with a clinician. Really important here is that we were much more inclusive in our inclusion-exclusion criteria compared to prior trials. We wanted this to be the most generalizable sample possible when we think about what things look like in the real world. We know that comorbidity is the norm. So we took co-occurring depression as long as anxiety was primary. I think this is going to be really interesting for partnering with the YSAM team over time to look at what we find. We took, ADHD again, as long as we felt like 6 months of exposure-based CBT was indicated. And I think that these differences will be really important as we understand outcomes down the line. Kids who were assigned to the combination arm got to pick their medicine with their pediatrician. So we offered 3 common medications with strong evidence base, fluoxetine, sertraline, and escitalopram. And really, we wanted, again, just practices that seemed more like what might actually happen out there when you meet with a provider, discussing a diagnosis, thinking about, whether somebody else in the family is on a medicine, if there's any history with meds, all of those things that our child psychiatrist colleagues are doing to make the right decision with kids and families. We wanted there to be some degree of choice. We had a prescribed schedule for med visits. You can see it here. They were monthly until remission, and then tapering to every 3 months. Phone calls as needed. Really important. We wanted a schedule that pediatricians felt like they could manage in very busy primary care settings. We also wanted them to have access to child psychiatry consultation. So we were fortunate that Jim McCracken was the study physician, for much of the study, and it's now Ben Schneider who is leading these consultation efforts. But I think everything from managing side effects to considering a switch, we've had good help on board so that people could talk through things when they needed to. We based our CBT protocol loosely on Coping Cat. Again, Coping Cat was originally designed to have up to 20 sessions. We wanted, based on stakeholder engagement, to offer up to 6 months of acute CBT treatment. And we wanted this to allow more flexibility to integrate family as needed and to allow more time for exposure practice. Because of the pandemic, which happened not long after this study, we ended up offering treatment either via telehealth or in person. Certainly for a stretch of the study, all of the treatment was in telehealth, and that will be something that we'll have to consider. But I think as we wrap up the study, we've got families really utilizing and leaning into having a choice here, which has been nice. A big theme in our administration has been flexible CBT treatment. These kids are by design going to have more comorbidities. We wanted people to really lead with what Phil Kendall has called flexibility with fidelity. We know the core components of CBT treatment: psychoeducation, cognitive restructuring, self-soothing exercises, problem solving, and of course, exposure. We want to teach these skills. We want to practice skills. But we also want to allow therapists room to do what's needed. If there's family conflict, you're going to meet with the family. If a kid has depressive symptoms and behavioral activation seems important, like let's do it. Behavior reward systems, being more centered for our kids with externalizing symptoms. Our therapists were really encouraged to be principal guided as they were being flexible. So we have been monitoring the techniques that they're using, emphasizing exposure-based CBT, but saying, if you're using other strategies, our expectation is that they're evidence-based. And of course, we're tracking them. This treatment is being provided by a network of community therapists all over the city. Some of them are trainees here at UCLA, some of them are PhDs, social workers, MFTs. I'm really, really proud of the PK team. They have poured so much time and energy into finding providers who take insurance, providers who take Medi-Cal, providers who speak Spanish. This is really the first time in my 20 years in the program that we have started to build kind of our dream network. And there's still a ton of work to be done, but it feels really good to be able to offer more options to kids with different levels of need and ability to pay. Our pediatricians are providing the meds, as I said, and everybody has undergone standardized training. I mentioned the consultation support for pediatricians, but our therapists are also asked to do consultation visits as well. At least twice during the course of their 6-month treatment, they check in so that we can see what's going on with their cases and continue to encourage an exposure-based approach. I'm going to move a little more quickly because I'm mindful of the time, but I mentioned that our outcome is remission. This is a little bit unusual, but we are measuring remission using the Clinician Global Impression Severity Scale, using scores of 1 or 2. So for those of you who are familiar with the clinical trials literature, or who have already rotated through ABC as part of your training, the CGI-S is a standard metric in clinical trials. Typically, it is a measure or a rating that's assigned by an independent clinical evaluator. It's not typically assigned by patients and parents themselves. A score of 1 or 2 is basically no symptoms or very minimal symptoms. And what it amounts to is a clinical Likert scale. And we chose it because we felt like in some of the data, in some prior work from CAMS, we could see that parent ratings pretty closely matched clinician ratings in many places. And this is a measure that they could be trained on that's very easy to use, very scalable, and it could be readily disseminated to the community. And you can see here that we have lots of graphics and illustration to help kids and families learn to use these measures. As I mentioned, we are really, this is hot off the presses, and I'm not going to go too deep into the actual data we've collected because we still have kids in treatment, but we got 903 referrals, and as you can see, ended up with a total randomized sample of 246 kids. This is, not quite what we aimed for at the outset of the study, but I think given the intervening pandemic and really its distinct impact on a study that was based in primary care, we feel pretty good about where we've landed. I do want to highlight, though, what we can see already and what was very evident to us throughout the study, which is that when families declined the study, so they were referred, by their pediatrician, we think you might have an anxiety disorder. They talked to the study team. Those who made it to that stage and then said no, 63% said no because parents were unwilling to consider an SSRI for anxiety disorder treatment. Now, there's lots of possible reasons for this. These kids might not, it's possible they might not be as sick, or parents might not have been thinking about an anxiety disorder. Again, in CAMS, everybody was treatment seeking, and here the pediatrician might be the first person putting it on their radar. But I think that this is important, again, as we think about what the evidence base is telling us, and also what patients and caregivers want. Here is just a quick sneak peek at what we're finding in our sample. This is across all study sites. So SCARED is our anxiety symptom severity measure. The CASE is a measure developed here at UCLA by John and Audra Langley. It's our kind of anxiety-specific impairment measure. And then you see that CGI severity rating that kids, parents, and clinicians did on admission or at baseline. We can also just look at some of these scores in comparison to the CAMS sample. So first column here is CAMS, second column is, center column is CAMS, right column is PK. And I think you can just see already that on some key indices, the PK sample with those looser criteria, it is looking to be a little bit sicker, a little more severe. So this will be something for us to track over time. We have really just started to bring together kind of these descriptives for our sample. So I wanted, having shared with you our enthusiasm and our excitement about this potential model for treating kids, to at least give you a preview of what's to come. I'm realizing here that I don't have basics on sex and age. These kids are coming in at roughly 12 years of age, and you know, as expected, roughly half are male. So we don't yet have outcomes for you all, but we hope you'll stay tuned. We're really excited to see our opportunity for data analysis on the horizon. And we really do hope that because these kids are connected to pediatric primary care providers, that we're going to have a real opportunity to follow them long term, to build on what we did in CAMS and in CAMELS, but also to kind of take this work to the next level. And we'll be ideally situated to do that because our hope is that they're going to stay connected to those pediatricians over time. With that, I just want to thank our amazing group of collaborators. Again, I've mentioned John and Jim throughout. Catherine Sugar is our fearless statistician. It's not trivial combining data across sites, piecing together these longitudinal trajectories across studies, which she has done time and again for us. Ben Schneider is our study physician, and John Walkup is the PI at the Prime site at Northwestern. Jeff Strawn is at Cincinnati. Joan Asarno is our COI collaborative care expert. And Helen Kaw and Isabel Enriquez make pretty much all of the work possible by herding cats and keeping us on track. So with that, I'm going to stop, and thank you for your time and attention.
Thanks, Tara. That was a really amazing talk. So much information, and it's going to be really exciting to hear about the outcomes. This was a Herculean effort, and you played a tremendous role obviously with Insight as our leader, but across the sites as well. There are a few questions coming in, but I'm going to take the prerogative of asking the first couple of questions, and people, please feel free to enter questions, I guess, into either the Q&A or the chat function. The first is, it's been an amazing task pulling together this community therapist network, and even more broadly, the pediatricians as well. Post PK, what are your thoughts or plans for how we can keep this going, or is that something that you think would be worth the effort to do?
I think it's absolutely worth the effort. You know, I still remember how sheepish I felt reaching out to our pediatrician partners and colleagues. I didn't have, you know, other than my training here, kind of pre-existing relationships with them. And they were all, I mean, just the warmest, kindest, most amazing people, and very willing to collaborate. But they weren't doing it for me or for you. They're doing it for their patients. And, you know, a big theme is it's so hard to get these kids care. And all of our clinics have wait lists, and we're trying so hard to, you know, address that challenge. But we need community clinicians who provide evidence-based care. We need clinicians who provide culturally humble and, you know, responsive care. And as we built this network, it's been so neat to meet them. just providers in really historically under-resourced neighborhoods saying, I'm doing this for my community and I want all the training I can get. And talking with them about and learning from them about the adaptations that they make that they think are important. We really hope to maintain this network, to continue to grow it, ideally to expand training to include, certainly the other things under our program umbrella, but I think we should dream big and be really ambitious here.
Great, thanks. We have a question from Mary O'Connor. Great talk. Could you comment on the usefulness of the mini kid versus the kitty sets for research in this area and maybe ADHD?
Oh man, this is such a tough one. I truthfully don't love the mini, but it is very easy to use. For those of you who aren't familiar with it, it's developed by the World Health Organization. It's designed to be extremely lay friendly, to be administered, really by people with all levels of training, including very little training. I think that it is a sufficient, as a semi-structured diagnostic interview, it is good in the sense that it is providing that framework and structure to make sure you hit everything and you don't forget anything, but the screener questions are pretty broad, and so they do require the clinician to have a pretty good understanding of psychopathology. And so in our program, almost everybody gets training in the ADIS, and I suspect that ADIS training informs their ability to use the mini. I think for parents, it's perfectly fine because we can juxtapose it against, we had lots, as you would imagine, lots of anxiety measurement, lots of depression measurement. And so we were able to kind of collate around it. But I think the biggest strength is it's short and easy to train.
Yeah, if I can comment, after doing all of these efficacy trials, the CAM study, I believe it was the intake assessment was about 8 to 10 hours over 3 separate visits. And the idea of actually trying to do something more feasible and easier for parents was very appealing, but kind of terrifying because we're so used to these mega evaluations. And in PK, there were a lot of decisions made to really try to make it more user friendly. And I guess we'll see if it worked, right? Once we look at the data. David Miklowitz has a question. Is it necessary for exposure to follow cognitive restructuring, or could exposure come first given its apparent strength, especially in settings where number of sessions is limited?
I love that question. Thanks, David. No, I think that this is why the flexibility matters. Particularly if you have a 7 or 8-year-old, it's really challenging to do these cognitive restructuring exercises. The developmental limitations are real. And I think you can sort of introduce it topically as a theme with cartoons and thought bubbles, but you don't get as much bang for your buck there anyway. And I think we really favor going straight to exposure. I think that you could do a lot of these things out of order, and getting kids practicing being in more of an approach mindset is really where it's at. And I think actually when you do that, you give yourself more to work with for some of these kids with the cognitive strategies, because they can actually say things like, I've done this before, I can do it again. Or I'm always afraid of this and it's never as bad as I think it will be. So they can anchor it in their own real world experience, which I think is nice.
Here's a question from Jonah Sarno. Amazing
Oh my
work.
God, it's like all of the giants of this division are here. I was hoping I was speaking to
Right. You
my
might want to
lab.
put a little light over your head like you're under interrogation here, but no,
All
these
my
are
heroes.
amazing work and contributions to our ability to bring state-of-the-art care to our kids in the settings where they receive care. You noted that PK was designed as a comparativeness trial and contained many components of usual care, but also had controls similar to efficacy trials. With perspective gained, what challenges do you think are most critical for us to address in order to truly integrate evidence-based care within routine practice settings?
Oh man. I think, Joan, it's such a good question, and I know it comes from all of your decades of doing this kind of work. I'm excited for the primary outcome paper, whatever it tells us, but I really think, for me, the big paper that will come out of this is going to be a lessons learned paper, probably definitely in close partnership with our pediatricians. We set this up to allow flexibility across sites in terms of how we structured these collaborations. And I think we saw very early on that that mattered. Um, UCLA was fortunate to have, and you said this from the beginning, Joan, put your people on site. That was very hard during the pandemic. We couldn't do that, but as soon as we could, PEDS has great psychologists embedded, and adolescent medicine has a long history of that with our interns. And so, having Courtney Kwan there on the front lines to triage cases, do some assessment, any whiff of anything could go to her, and she made it all work. Lurie has more of a consultation model kind of akin to our BHA. And in their community practices, it was different still. And then I think we really saw that Cincinnati, without either of those strategies in place, really struggled to recruit. And so I think, my observation is that it's in best when you can, it works best when you can fully co-locate. But if you can't do that, I think thinking about next best options is key. And I'm still puzzling over, what we can realistically do about universal screening when it seems so ideal, but so darn hard to actually do.
It's almost 10. I'm going to take the prerogative of last question. So it's recruitment for PK was almost exactly 20 years post that for CAMS. And CAMS was a very highly controlled clinical efficacy trial, and PK is really this beautiful community, collaborative care study. And there were some pretty significant differences in terms of the severity levels of anxiety across the two studies. And you're talking about loosening the eligibility, and in my mind, the first thing would come to mind is that would bring in a milder sample. Because we're always trying to, the last run when you loosen, you typically are bringing in people that may be less eligible in that regard. But it looks like it's the opposite here. Do you have any thoughts or ideas about just the different settings, or does 20 years make a difference? Are kids different now?
I don't know. I feel like we're teeing up nicely for your talk in a couple of weeks about, youth mental health and social media and kind of all the things that have changed in the landscape for kids. I I wonder about this too. I do think that things have changed a lot for kids. Sort of the ecosystem that they live in is pretty different than it was 20 years ago in terms of the things that worry them. Um, from school shootings and climate change to social media, all of this stuff is really well documented. And I think we have a lot of data suggesting kind of just generally climbing rates of mental health problems for kids. So I would expect alongside that to see higher levels of acuity. That being said, we really thought that if we were there in primary care, we'd be catching them in many cases before they had thought about disorder, and that they would be more mild. And so I too was a little surprised when those numbers came in, approximately 48 hours ago. Thank you, Catherine. So I think I'm really eager to do a full side-by-side comparison of the samples. I'm really interested in looking at the race and ethnicity data. Um, I think, we treated a very large proportion of Medi-Cal cases. We really aimed to be meaningfully more inclusive here. But the proof is in the pudding, and I want to see sort of what our numbers look like up against CAMS and other prior trials. And those data weren't quite ready yet just because of the idiosyncrasies of how people reported and a little cleanup that's needed.
Okay. Well, thank you for a really wonderful presentation. It was great being able to host this for you. But the work is really remarkable, and you've done an absolutely amazing job steering this giant bus.
Well, thank you for moderating. Thanks to all of you for attending. And I have to say, it's maybe just a final remark that it's really a privilege to get to present this work, because I do feel like I have been mentored deeply and lovingly by this community ever since I arrived. And all of the clinical trials experts who are putting in questions have really poured a lot of time into helping me think about my work and my career development. So Thank you for being here, and I look forward to yours in 2 weeks, John.
Thank you.